So now, without further delay, I would like to invite Dr. Dipti Chaturvedi ma'am to take over this session. Ma'am, kindly proceed with your talk. Over to you, ma'am.
It's not my talk, first of all. It is our talk. It's a talk of all of us because we are all women and breast cancer is mostly related to women. So, welcome and it's a good evening to all. It's really a very proud privilege for us, Dr. Chaturvedi Cancer Hospital, to be associated with Clirnet. This is the first meeting of ours in association with them. And still we are with the Oncology Integrated Society members. So we welcome all of you once again. And as we know, the incidence of breast cancer in US is around 264,000 cases per year in women and 2,400 cases in men. So see in the developed world, how much is the burden? Among these, around 42,000 females and 500 men, they die each year in spite of the best technology with this disease. In India, the breast cancer has ranked among the #1 cancers in females, and it is age-related. It is as high as 25.8 per 100,000 in females, and the mortality is 12.7 per 100,000. In every 28 women, one is likely to get a breast cancer in a lifetime. It is more common in urban area than in the rural. So this demands for us to know why it is so. And so even if we know why it is so, can we change things? Can we do lifestyle modification? But most of all, what is important is to go for breast screening so that we can go for early diagnosis of breast cancer, even if it is there, and not wait for the last stage or the fourth stage and go for metastasis. So for all this, we have eminent speaker, Dr. Rashmi Shukla, eminent radiation oncologist at Max, Delhi, and very old, experienced, renowned private practitioner and an oncologist of his time, Dr. A.K. Chaturvedi, proprietor of Chaturvedi Cancer Hospital, and UPARI president, past president. He has many theses and he has been co-guide to many theses and has publications and awards to his credit. Over to you, Dr. A.K. Chaturvedi. Please introduce the speaker. Thank you.
Thank you, Dr. Dipti. Today is a very important topic which is Dr. Rashmi Shukla is going to speak on. As you know, the carcinoma breast is very common and it is easily detected if a person is little bit conscious about her health, about her body. Dr. Rashmi Shukla, she is consultant radiation oncologist. She has 13 years of medical experience and currently she is working as consultant radiation oncologist at Max Hospital, Patparganj, Delhi. She has done DNB, Mahavir Cancer Sansthan, Patna, MBBS from Bahrampur Medical College, Odisha. She is member of many organizations, renowned societies like AROI, Astro, ISO, IBS, IMA, and NESMO. Her special interests are IMRT, IGRT with rapid arc, VMAT, stereotactic body radiotherapy, stereotactic radiosurgery, brachytherapy, total skin electron therapy, and total body irradiation. She's going to speak on early detection on carcinoma breast. So, Dr. Rashmi Shukla. Dr. Rashmi, over to you. You can continue.
Thank you so much, sir, for a very kind introduction. Thank you so much, and a very good evening to all of you. So let me start sharing my screen. Okay, Prachi, and is it full screen visible, Prachi?
Yes, ma'am. It is.
Very good evening to all of you. I am Dr. Rashmi Shukla. I am consultant radiation oncologist at Max Hospital, Patparganj, and I am working here since last 10 years. So I will start my talk with Nari tum keval shraddha ho, Nari tum keval shraddha ho, Vishwas rajat nag pag talve, पीयूष स्रोत सी बहा करो जीवन के सुंदर समतल में जीवन के सुंदर समतल में. As we know that cancer is a growth of abnormal growth of normal cells in an uncontrolled way in a progressive disease. As we know, the symbol of cancer is crab. That is, there is a hidden truth is what we are seeing or visible outside. There are so many deep-seated truths which are hidden inside it. And we know that 4 out of 10 cancers are prevented by simply changing our lifestyle and some modification. So today, let's concentrate on breast cancer. So today, I want to share you that can you and me try to do something to prevent cancer? Yes. So let's talk about we are going to discuss only and only about the breast cancer. According to the Globocon 2020 data, breast cancer is one of the highest incident cancer in the world as well as in India. And the mortality due to breast cancer is also very, very highest. As we are going to discuss about the screening in breast cancer. So why to screen? We are doing to screen because its incidence is high, mortality is high, and if we detect the cancer in early stage, then we are going to achieve a cure rate of 90 to 95%. So that's the basic rule of screening to have in a general population asymptomatic patients to detect early stage and to have a good local control. So what are the symptoms of breast cancer? As we know that there is a lump, axillary lump, or any skin changes, pimpling, redness over the skin, nipple discharges. These are the normal changes of breast cancer. But these all are in a very, very, very advanced stage. So just look, this is a fungating mass. But before going and becoming to a fungating mass, it will start with a very small lump, which we can detect with a screening method in a very, very early and small stage. As we know that in India, we are detecting the cancer when the first time we are detecting the cancer or diagnosing the cancer, the lump is 4 centimeter, 5 centimeter, 10 centimeter, or skin fungation or to metastasis. But in West, they are having a very strict screening protocol. That's why they are detecting a breast cancer of size of 0.2 centimeter, 0.5 centimeter, 1.2 centimeter. So they are detecting at stage 1 and we are detecting at stage 3 and 4. So this is the benefit of screening. So as before going to the screening, let us discuss some of the risk factors which are associated with breast cancers. So some are modifiable and some are non-modifiable risk factors. We go one by one of that. As we discuss that age, as the age increases, the risk of breast cancer increases. The data says that 1 out of 8 invasive breast cancers are found in women in less than 45 years. But beyond 55 years, 2 out of 3 invasive breast cancers are found in women. So the main message is that as the age increases, the risk of breast cancer increases. Gender. As we know that the common society says that as female, the breast cancer is only and only disease of female. No. Male are also at high risk of breast cancer. Per year, we are treating 2 to 3 breast cancers in our hospital. So it's a dictum. It's not a dictum that the female will only and only are having the breast cancer. Males are also the risk of breast cancer. We have found that some race and ethnicity, like white women, are slightly at high risk than African American women but the risk of death is lower. So less than 45 years of age, more common in African American women. Asian, Hispanic, and Native American women having a lower risk. Family history. This is very, very important that first or second degree of relative, if they have the breast cancer, they have a higher risk and incidence of breast cancer. But the most important message is that not all the family have the breast cancer and their daughters and sisters will get the breast cancer. Hereditary breast cancer runs only and only in 5 to 10% of the population. And it also depends on the number of relatives affected, exact relationship and age at diagnosis, and there are several risk assessment models to assess it. Personal history. This is a very important that a woman with a breast cancer, they have 3 to 4-fold increased risk of having the second malignancy in the contralateral breast. That's why we advise that a routine follow-up is very, very important. We have found that after 5 years, 10 years of getting cured of breast cancer, they usually think that now we are okay and there is no need of routine checkup. But this is very, very important. Even we have found that ER/PR positive, highly good favorable prognosis, even if at 15 years they have the risk of metastasis. So annual follow-up in those patients are very, very important. Menstrual history. Am I audible, Prachina? Hello? Sir, am I audible now?
Yeah, yeah.
Yeah.
You're audible.
At times,
So,
you are audible.
So menstrual history, we say that early menarche and late menopause have slightly higher risk of breast cancer because of estrogen exposure. Parity. Nulliparous and first childbirth after the age of 30 years have slightly higher risk of breast cancer. But these are a modifiable risk factor and these are not an absolute risk factor. So I want to take home message will be these person or these are all are having high risk of breast cancer. But it doesn't mean that a lady who is having first child at 35 years, definitely she is going to having the breast cancer. No, not like that. But because of today's lifestyle modifications and so many changes in our society, so this is also an increased risk factor. Breastfeeding, the data is not very strongly supporting, but this says that breastfeeding, they slightly lower the breast cancer risk. Hormone therapy after menopause. So combined use of HRT slightly increases the risk of breast cancer and may also increases the risk of breast cancer, but simultaneously with coronary artery disease, stroke, pulmonary embolism, these all risk also increases. And it increases the risk in cases in advanced stage of presentation. But the data says if you stop after 5 to 7 years, that there is a risk is reduced. These all are not very strongly suggested, but they say that dense breast and oral contraceptive pills. So few papers say that oral contraceptive, even 4 years or 5 years of continuous use increases the breast cancer. But some data have also there that even after 15 years of use of OC pills, there is no risk of breast cancer. These are something non-modifiable risk factor. Coming to a modifiable risk factor, we say that alcohol is directly and linearly related to the increased risk of breast cancer. Obesity and the body mass index, as it keep on increasing, the risk of breast cancer increases. Diet, obviously the green vegetables having the micronutrients, they are indirectly related to a decrease in breast cancer risk as well as the physical activity. So this is a very important slide I want to highlight is that, and the take-home message will be only 5 to 10% breast cancers are hereditary. So now at this time, we are routinely doing of BRCA1 and BRCA2 mutations of certain stages of breast cancers. And if you found that there is a high risk of BRCA1 and BRCA2, then we are doing these tests on their daughter, sisters, or relatives for having the germline mutations. So only and only 5 to 10% risk are hereditary risk of breast cancer. So we have just discussed the incidence, the importance of screening, why to do screening, and what are the risk factors associated with the breast cancer. So now the main topic is what are the important tools of screening, how to do it. There are so many guidelines for screening, different guidelines. They are saying that some says different A's, some says different tools. So let us clarify that, and we should have to take home message that in an Indian scenario, with the financial constraints, social constraints, so many issues, what we are following at Max Hospital. So in screening, we have the 3 tools. First is breast self-examination, clinical breast examination, and mammography. Ultrasound supporting to the mammography, and MRI or MR mammography in a very high risk case. So these are the important tools. But what I found is that the self-breast examination is the most important tool, and the awareness to the female that if you have any lump in your breast, at least you should report to your nearby doctor, physician, oncologist, or at least a gynecologist to have at least a clinical examination of breast. The most important message I want to give is that not all the lumps are cancer. So we found that I have seen so many patients that at 30 years, 40 years, even I want to give a very beautiful example that we have done a screening mammography camp in ONGC. And at 56 years, we have found that mammography has detected a bilateral 4 lesion. But when we did an FLAC biopsy, we found it as a benign lesion. And finally, we did excision and we found that it is a benign lesion. So what I want to convey the message is that not all the breast lumps are cancer, but at least you should have a proper checkup of that. And even if it is a breast cancer, it comes out to be a breast cancer, but early detection, early treatment will save you from lot of problems for them. So let's discuss these tools first. So breast self-examination. So this is also, it's a saying that we should just do examination of breast. No, but we have to do in a proper way, in a regular manner, as well as this you have to spread in your society, neighbor and all that. No, these are the methods how to do it properly. So I will just explain in a short time that what is the basic and correct method to examine the breast. First is we have to divide the breast in 4 quadrants and as well as in central quadrant in which there is nipple and areola is there. So if we have just examined the left side of breast, so we have to use our right hand to examine the left breast and vice versa. So first we have to divide the 4 quadrant Then we use the 3 fingers and the pulp of these 3 fingers, and we have to just press it. Because if we examine like this, then the whole breast, we will feel that it is a nodular breast. So we have to use three fingers with the pulp, and we have to just rotate and press. Then just rotate in 360 degree. So just rotate, press, slightly move up, rotate, press, then slightly move down, rotate, press in a 360-degree angle. Then we have to use this finger to examine the nipple and areola area with this and with this to feel. Sometimes or most of the time we feel that there is a retroareolar lump is there, or by pressing the lump we will get some discharge. So simultaneously we come to know that there is a retroareolar lump or any discharge from that. So in the 360-degree manner, in this. The most important point what we miss is that we have to just under surface of the breast, because in the what I want to give the example is that ONGC lady said that she is educated and in a very good post. She told that I always examine my breast, what we have seen in the YouTube and all, but I never found a lump. But that lump was situated in the inframammary fold. So most of the time, sometimes we feel that we found that there is some lump in the inframammary area. So these areas should also be examined. Then axilla or armpit, you will do in the same with in the right axilla, the left axilla, you have to do with the right arm and the same manner like that. So this is a breast self-examination. What I found is that the breast self-examination is a very, very important tool. Because even I have given so many talk on these screening protocols and all, what I found is that around 80% of the population, even if they are in a higher post, but they don't even know that what is mammography. So this is the level of lacking of awareness about the mammography in our country sitting in a Delhi. So I feel that if I leave this Delhi NCR, I don't find that anyone know about even the mammography. So, and even they have so many centers and so many places, even they don't have a very good facility of mammography. So what I found is that breast self-examination is a very, very important tool, which the tool is within your hand. You have to only do it in a proper manner. So second is examination by the doctor. That is also very important. So I will discuss further in how to just do this examination by the doctor, at what duration and all. And the third is the mammography. So mammography is a simple imaging using a low dose X-rays in which we are compressing the both breast craniocaudally and the mediolaterally. So mammography is just like an X-ray films, just like an X-ray machines, and the films are like X-rays. It is just to compress, the two plates are there which are compressing, and we are having a craniocaudal and mediolateral oblique views. And just few lines about few points, the important points and take-home messages about the mammography, that now there is so many advancement in mammography. Like initially we have 2D, now we have 3D and digital mammography with so many edit software, so that it technically improves our reporting and the clarity. Like if we have in doubt, like in our digital mammography, if we have doubt of some lesions, then we have spot compression view to have the separate summation shadow of the suspicious lesion. We have the magnification view of the calcification sometimes in films if you have doubt. So mammography, but the disadvantage of mammography is that if you found a very dense breast, so what we found that at the age of 33 years also, the breast is not so dense. And at the age of 48 years also, the breast is, we found it so much dense. So if the breast is so much dense, then the quality of mammography we are getting is not so good. So that's why we are saying that a digital mammography, it has so many very good advantages, and having a better viewing and achieving a long-term storage and having a lower radiation exposure also. So still, it's a radiologist work to just define and just to read the mammography. So the mammography is reporting in the BI-RADS manner, that is breast imaging reporting and data system classification, that we called as BI-RADS. This slide is not coming properly. So something happened in this slide, I don't know what. So let us discuss this slide, because this slide is very important. So when the reporting is BI-RADS 1, Prachi, is it visible, Prachi? Prachi?
Yes, it is visible.
Okay, sir. So BI-RADS 1, it is a normal reporting of mammography. BI-RADS 2, it is almost a benign lesion, having the less than 2% chances of malignancy. BI-RADS 3 is probably benign, but it needs a very close follow-up. So BI-RADS 1, normal. BI-RADS 2 is benign. BI-RADS 3 is probably benign, having less than or equal to 2% chances of malignancy. So in BI-RADS 1 and 2, nothing to do, 1 year follow-up. But in BI-RADS 3, when the patient is having mammography of BI-RADS 3, there is still less than or equal to 2% chances of malignancy. So in this case, we just tell the patient to having a close follow-up 6 monthly or 8 monthly. But BI-RADS 4 is suspicious lesion. So we cannot leave BI-RADS 4, but sometimes still the mammography have the sensitivity of 90% and specificity of 90%, 95%. Still there are chances of false positivity are there. So in BI-RADS 4, still they have divided in 4A, 4B, 4C. So in 4A, it is a low suspicion of 2 to 9%. BI-RADS 4B, it's a moderate suspicion of 10 to 49%. And 4C, it is a highly suspicious, that is 50 to 94% chances. So basically, the BI-RADS 4 is a highly suspicious lesion. And in BI-RADS 5, it is a clear-cut malignant lesion in which more than 95% risk of malignancy is there. One most important category is BI-RADS 6, that is already biopsy proven malignancy. So anyone outside, they have just done an excisional lump like that and they found it malignant, and then when we do the BI-RADS, then it is biopsy proven malignant lesion, and they just denote it as BI-RADS 6. There is also a category that is BI-RADS 0. BI-RADS, the slide is, I don't know why it's coming very rough. So BI-RADS 0 is that there is a dense breast, or the picture and film is not very adequate, and we need any additional imaging to support our diagnosis. So in that cases, because if the breast is very dense or the PIB films are not taken clear, then we just do it sonomammography, means we are using the ultrasound to just having the confirmation what we found in mammography. So I will repeat it. BI-RADS 1 is normal. BI-RADS 2 is benign. BI-RADS 3 is probably benign, having the less than 2% or equal to risk of chances of malignancy. BI-RADS 4 is suspicious. 4A is low suspicion, 2 to 9%. 4B is moderate suspicion, 10 to 49%. And 4C is highly suspicious, that is 50 to 94%. And BI-RADS 5 is clear-cut malignant lesion having the risk of malignancy of more than 95%. And BI-RADS 6 is biopsy proven malignancy is it needs any additional investigation to diagnose. So these are the standard reporting system in which the mammography, they just have the reporting and looking after the breast composition, important findings like mass, asymmetry, architectural distortion. Calcification is very, very important in proving the malignancy. So they have the microcalcification more than 500 to 500 micrometer. So calcification is very, very important findings, but sometimes some cancers like lobular carcinoma, they don't have so much of calcification. Hello? However, where are you? And so we recommend these all in the following headings. So in mammography, we report at breast composition, mass, asymmetry, architectural distortion, calcification, and associated features. So the parameters which they are looking after in while reporting of bilates, like the breast parenchyma pattern, mass or sphere, size, shape, characteristics, the margins, whether it is lobulated, spiculated margins are mostly they are of malignancy related. Density, how dense it is, and the architectural distortion, any lymph node is not there, any asymmetries in the breast and the tissues, so calcification. So these all are benign calcification. These all are microcalcification. Some are suspicious calcification. Sometimes we found it that no, it's malignant or not. And there is different morphology of the calcification itself. So if there is a malignant, it has fine linear branching and pleomorphism. So this is characteristic of malignancy, and associated changes like skin retraction, nipple retraction, skin thickening, or trabecular thickening, or sometimes the axillary lymph node is there. And sometimes we have to need a sonomammography. So in our hospital, we have a dedicated breast radiology reporting system for the oncology from the last 10 years. So even if when we found, even our technicians are so much trained that even if they found something suspicious or not right, immediately we do a sonography to just correlate and to give a final diagnosis immediately. So these are the breast ultrasound. Then coming to the screening guidelines, these are the most confusing because American College of Obs and Gynae, US Preventive Service Stars Group, American Cancer Society, and NCCN. They all have different guidelines for having the screening, and they have different protocols, different timelines. So what at our Max Hospital, we have formulated one guidelines that we will follow like in this manner, so that we can have at least do something, because we cannot follow strictly like the US protocol is there. So data and the guidelines says that breast self-examination we should do monthly after 20 years. So after 20 years, every month, we should recommend breast self-examination. So how do we remember? So what I tell that we can remember like our birthday date or anniversary date, so that we can do a breast self-examination by ourselves just before the date of birth. So it will just routinely do that. We cannot miss this. Clinical examination by doctors, all different guidelines says that within 20 to 40 years, every 3 yearly, and 40 years, after 40 years, every yearly clinical examination of breast by an oncologist or gynecologist or physician should do this. And the guideline says that at the age of 40 years, at least one mammography should be done. But what we generally recommend is that between 40 to 45 years, at least one baseline mammography should be done. So we just spread the awareness and try to convince all the normal population or wherever we are going to have a talk that at least between 40 to 44 years, one baseline mammography should be done. And after 45 years, every yearly mammography should be done. And after 55 years, every 2 yearly for the continuation of the mammography, we should do the every 2 yearly, that is biennial mammography should be done. So different guidelines, some guidelines say that how long you will do the screening mammography. So some say still at the age of 75 years, we should keep continuing to continue. Hello. हाँ ठीक है ठीक है. So sorry. So US guidelines says that at least up to 75 years of age, you should do a screening protocols. But other guidelines say, and what we follow, that the mammography should be annual screening or at least 2 yearly biennial mammography we should do, at least up to when the woman is in a reasonably good health. Because we found that sometimes at 80 years, 85 years, we have found that the breast cancer patient is having the breast cancer. So the recommendation is up to as long as the female is in a reasonably good health. So there are some high-risk protocols for the screening. So these are for a general population. All these guidelines are for a general population. For high-risk population, the slide, I think it is missing from my PPT is that. So we recommend screening for a these are for high-risk population. So we recommend that, and the guideline says that MRI is the best tool for having the screening in the high-risk cases. So it is for having BRCA1 and BRCA2 mutation, or any females, any patient who is having a first or second degree relative with having a BRCA1, BRCA2 positive, or any patient having a radiation history of chest radiation between 10 to 30 years of age. So in all these high-risk cases, we recommend MRI at the age of 25 to 30 years along with mammography. But these are for high risk, so I don't want to confuse it. So these are the general recommendation for a general population. So I will end my talk with these few lines that आंसू से भीगे अंचल पर मन का सब कुछ रखना होगा. आंसू से भीगे अंचल पर मन का सब कुछ रखना होगा. तुमको अपनी स्मृति रेखा से यह संधि पत्र लिखना होगा. So the last message I always and always deliver to her that कि आप एक every female is एक अच्छी माँ है, एक अच्छी बहन है, एक अच्छी पत्नी है, सब कुछ है. But आप अपने लिए कब अच्छे हो? So please take your time for yourself. Just follow the routine screening protocols to detect the breast cancer in an early stage and to treat it properly and to have a very good quality of life. Thank you so much for your patience listening. Thank you. I think I took 45 minutes. Thank you.
Thank you, Dr. Rashmi, for the nice, beautiful presentation and in a very easy and understandable language. How to examine breast, which are the risk factors, what is the incidence, how to detect it early, and what is BRCA1, BRCA2, and how it is going to help the woman of high risk to get the thing examined, and the importance of mammography and MRI, when we should go for mammography, when we should go for ultrasound, ultrasonography, and when we should try for MRI. That's very nice presentation. It's very good, and I think the viewer will take the benefit and spread the knowledge to the public. This is basically for the public interest, so that it can be percolated in the general population, so that they come in the early stage and they should pick up the early lesion. That's the nice part of it. Thank you, Dr. Rashmi. Thank you very much.
Yes, thank you, Dr. Rashmi Shukla. Yes, we enjoyed your deliberation. It was really very elaborative and informative. And I know it will benefit all our IMA participants and Foxians and many non-medical also. participants. And thank you for being a lovely orator. And thanks all the audience participants for being lovely audience. And thanks the technical team for the unhitched and unclinched smooth running of the webinar. I know you are in hurry, so I'm just ending it here. There are many questions and many cases to be talked on, but we'll leave it for the next time. Thank you so much. Thank you, Clirnet,
Thank
for
you,
being
ma'am.
with us together.
Thank you,
Okay.
everyone, for sharing such valuable insights. We are more than grateful to everyone present here. We hope to have you again on our platform very soon for our next sessions. So, with all your permission,
Sure.
sir and ma'am, I would like to sign off for today.
Yeah, we too. Thank you all.
Thank you so much.
Okay,
Have
bye.
a
Good
nice
night.
day.
Have a good night. Okay, bye.
Thank you, Bhaiya.